Kia ora koutou. Ngā mihi nui kia koutou. Welcome to our, where are we, March Tōmaiora seminar series. It's nice to see everyone here today, and before I get into introducing our special guest speaker for this month's seminar, I did want to stop and acknowledge the Muslim community and to recognise the hurt and trauma that they went through at the end of last week, and they'll be continuing to work through over the coming weeks and months. And it's been quite interesting talking to people and listening to the media, and it seems that there's quite a lot of focus on what we all can be doing next to support this community. And I thought there was an interesting article by Dame Anne Salmon in the Herald today, and so I haven't got my glasses on, just share some of her thoughts around this. And she says, let's not pretend that there's not a dark underbelly in New Zealand society. The rest of us have to name it, challenge it when it comes to light, and replace it with better ways of being. So I thought that was actually a nice way to capture what we all can be doing to recognise the people that have been most impacted by the events of last week, and also probably why we're all here together, because there's lots of people in this room that have been talking about and fighting racism over a number of years within academic context and health service provision context. So for that reason, it's my pleasure to introduce our speaker today, Professor Jeff Stone, who is the Professor of Psychology and Psychiatry at the University of Arizona. Jeff's research investigates the basic psychological processes underlying prejudice and stereotyping, stereotype threat, the reduction of intergroup bias, and mechanisms of attitude and behaviour change. Jeff has kindly come to Auckland and to New Zealand for the first time to share some of his research with us, thinking about implicit bias in healthcare, but also he's kindly offered to run a workshop this afternoon where we can be looking at the role of implicit bias for patient care and working with medical students. So I think it's a great offer that he's provided for us today, and it's really nice to have him here and to think about commonalities in his work and the work that we've all been doing here in Aotearoa. So thank you for your time today, Jeff. We're looking forward to hearing from you.
Okay. Well, hello. It's really wonderful to be here. Appreciate the opportunity to come and share some of the work that we've been doing. You know, totally heartbroken by what happened in Christchurch, and coming from the U.S., you know, it's something that we're dealing with quite a bit. I'm really hopeful that some changes that could happen here will maybe influence some changes in the U.S. in the way gun laws work. And it's such an explicit, deliberate, you know, example of hatred, right? And one of the things we remind ourselves a lot in the U.S. when it happens is that, you know, it's still a rare event. It's still, you know, thankfully not every day. And that, you know, I was a little kind of curious as to whether it would make sense to talk about implicit bias following an event like that. But the thing I think is important to think about is how the explicit form that we saw in Christchurch is not really kind of the everyday examples of the kinds of bias that people experience. I would make the case that, you know, the more subtle implicit forms that we are looking at in this work are sort of the everyday experiences, especially in a context like higher education or in healthcare. So let me tell you a little bit about the work by starting off with an example of the kinds of biases that I think that we're trying to understand in our work. This is from a really great book called How Doctors Think by Jerome Groopman. It's a story of an error in treating a patient relayed by an emergency room doctor, Karen Delgado, and she talks about a young man who was brought into the ER in the hospital in the wee hours. The police had found him sleeping on the steps of a local art museum. He was unshaven, his clothes dirty, he was uncooperative, unwilling to rouse himself and respond with any clarity to the triage nurse's questions. Dr. Delgado was busy that night attending to other patients, so she eyeballed him and decided he could stay on a gurney in the corridor, another homeless hippie who would be given breakfast in the morning and return to the streets. Well, some hours later, she felt a nurse tugging on her sleeve, and she said, "I really want to go back, and I want you to examine this guy," said the nurse. And Delgado was reluctant, but she had learned to respect an ER nurse who felt something was really wrong with a patient. And this is Delgado talking. She says his blood sugar was sky high. The young man was on the brink of a diabetic coma. He'd fallen asleep near the art museum because he was weak and lethargic and unable to make it back to his apartment. It turned out that he wasn't a vagrant, but he was a student, and his difficulties giving the police and the triage nurse information reflected the metabolic changes that typify out-of-control diabetes. So an example of where this ER physician took a look at somebody, decided that he was a member of a particular group, and then acted on that information, all I would argue in a very quick, automatic way. We know a lot in psychology about how these processes unfold, and this comes from decades and decades of research in psychology. It all starts with the natural way that we process information in our social environment. We have a tendency that when we come across any new object in our social environment, we try to categorize it as a way to understand it. And so, for example, I could come across this object, and I could take a look at its physical features, and I could decide, this looks to me like a bottle of water, which is wonderful because to the degree I know what a bottle of water is all about, I now know how to interact with this object, right? Well, we do the exact same thing with people. Whenever we come into contact with somebody brand new, we take a look at their their physical features, and we immediately can categorize them. And to the degree that we have information about what members of that group are like, that's what we call our stereotypes, we now can expect what's going to happen during this interaction. Most stereotypes, we know, break along two dimensions. They describe the group from warm to cold and from competent to incompetent. And you can imagine the groups that kind of fall into the quadrant of warm and competent, well, they probably get a lot of positive stuff, right? Because they're good, they're effective, they're positive. Of course, the other three quadrants pose problems because they start to bring together negative attributes, and we really worry about the kinds of groups that are characterized as both incompetent and cold, right? And it turns out many patient groups are seen that way. That, of course, can lead to discrimination in and of itself. So people can act on their stereotypes. Some of those stereotypes can be very active and harmful. And we can think about the events in Christchurch maybe as an example, an extreme example of what that can be like. But again, as I said, it's not the kind of discrimination that we see typically in healthcare or in higher education. It's more the passive but yet still harmful forms. Of course, we can't talk about this process without talking about prejudice. And when we think about prejudice, it's a different psychological construct. It's more our emotional responses that we have to people. Emotions like disgust can be pretty negative in terms of making us want to sort of get away from somebody that we feel disgust toward their group. I could put hatred, I could put anger up there. Those are common emotions that are associated with prejudice. We also can have positive prejudices. We can feel pride, especially about our own group, and that can lead to interesting forms of bias. Those are often independent of each other, although as you'll see in some of the work that I'm going to present, they often can go together. So this process is pretty well documented, from categorization to activation of negative stereotypes to feelings to then behavior, right? And we know that it can happen consciously and deliberately, right? And in the U.S., my president is Donald Trump. I hear it on a daily basis. Somebody consciously and deliberately, talking about stereotypes, talking about dislike, and often acting on it. But what we're interested in, again, in the context especially of healthcare, is that this process can also unfold unconsciously, implicitly, which is to say it can happen so fast that people don't know it's happening. They can categorize, activate stereotypes and or prejudices and act on them so quickly that they don't have any awareness that they're acting in a way that is being perceived as negative or having a negative effect on the group. So the research that we've been doing over the last 10 years or so is trying to address three main questions. One is, what are the biases that providers hold, nurses, doctors, staff in some cases? And do those biases come to mind automatically when they come into contact with certain patient groups? And then the second question is, how does that then affect patient care? Does it have an effect on the kinds of medical decisions that people make? Does it have an effect on the actual interactions that occur in a clinic? And then third is, if the first two are true, we'd certainly like to try to do something about it, if we could, right? We'd like to maybe try to provide an educational approach. And so we've been very interested in making implicit bias part of medical training for healthcare professionals. I'll show you an example of what we do with that today. And then the workshop, I'll actually run those at the workshop through what we do. The other thing that we've done some research on, not as much, but I think it's a really interesting question, and that is, can patients actually play a role in deactivating the biases of physicians? Can a patient say something, for example, that would take the stereotype off the table for the physician, so that the bias wouldn't even be relevant in that context? We have one study or one paper that looks at a couple of examples of that. I'm not going to spend any time on that today, because just to save time, but I think that's an important question that we should be asking. Okay, well, I'll just summarize quickly what we've been doing with respect to the first question. And we've documented implicit bias towards a number of different patient groups by a number of different providers. Hispanic patients, that's, I live in southern Arizona, 1 hour from the Mexican border, so Hispanics are the largest minority patient population where I am. We've done a number of studies, one of which I'll show you today, looking at implicit bias towards Hispanics. I've done some work on implicit bias towards African Americans. And we have a paper we're writing up now where we have some evidence of implicit stereotyping by practicing physicians towards American Indian patients. And then we just published a study, interesting because some of the implicit bias research is going away from race and ethnicity and toward other patient groups. And we found evidence in this study of gynecology care physicians and nurses showing implicit prejudice and stereotyping toward women with cervical cancer compared to ovarian cancer. And there's a similar study that I'm not part of that shows implicit bias towards women with lung cancer compared to breast cancer. And so you think about, what does lung cancer and cervical cancer have in common? They both have a behavioral cause, right? Smoking, sexual behavior. And so the one possibility is we're starting to learn that patients at an implicit level blame their patients for their illness. And of course, now the next question is, what implication does that have for care? So that's some of the work we've done in documenting the biases. And I'll go into more detail about how we do that in just a moment. What I do want to spend time on is telling you about some of the work we've been trying to do to figure out, so if these biases exist, do they creep into patient care? Does it actually affect the way that patients are interacting with physicians are interacting with their patients? And we've been especially interested in patient satisfaction. In the US, that's become one of the primary markers because health insurance companies are using it as a measure of sort of how good physicians are, and their pay is somewhat being affected by that. And so the physicians are very, very cognizant that I need my patients to like me after I'm meeting with them, otherwise I may not get paid, or there may be implications for how many patients I can see. Now, when you think about the role of implicit bias, I should use this pointer, implicit bias in affecting patient care, one of the things I would argue the literature seems to be pretty clear on is that there's a particular pathway by which implicit bias gets communicated when people interact, and it's largely a nonverbal pathway. And so what's been documented in the literature are things like doctors with high implicit bias, they talk more than the patient talks. They dominate the conversation. And that tends to relate to how the patient feels about how things went, right? So it's not very patient-centered care. Patient-centeredness, we can look at the number of rapport behaviors, for example, the number of open versus closed-ended questions that get asked. So doctors with high implicit bias ask more close-ended questions, right? Don't give the patient much opportunity to talk. And then affective tone, you can actually hear it when you listen to a doctor with high implicit bias interact with the patient. They don't sound happy to be there, right? And that the patient picks up on, and that affects their satisfaction rating. So there's a lot of sort of nonverbal behaviors. It's about how we talk to people that sort of communicates implicit bias. What we were interested in our research is there may be another pathway that is also happening automatically that people don't realize they're sort of using, and that has to do with what we call linguistic implicit behavior. So here we're talking about the words people use when they communicate and the way in which words play in social behavior. The belief is generally that people don't pay attention to how often they say I versus me versus we, right? And so some of the things that we were interested in come from a colleague of mine, Dr. Matthias Mell, who studies the relationship between language and social behavior. And he does a lot of work in health. And so, for example, he found some interesting things, which is that with cancer patients, there's an effect for language style matching. The degree to which a partner and a patient with cancer and their partner match their linguistic style. So they use the same articles, use the same prepositions when they talk about the illness. That predicts better survivorship for cancer patients. So matching up, sort of talking, it's like a synchrony between the way we're talking about the illness. One of the things we thought is, well, if you're interacting with a physician with high implicit bias, you probably don't sync up very well in terms of that language use. There's another language pattern that Matthias has found with cancer patients, and it's called physician-patient withdrawal, or it's called demand-withdrawal interaction patterns. And so again, when you have a cancer patient with their partner, the partner might say, you know, we need to get more exercise today, and the cancer patient will say, don't tell me what to do. So the partner's making a demand, the patient is withdrawing, right? That tends to predict poorer outcomes for cancer patients when that's going on. So we thought, well, maybe physicians with high implicit bias do more of this demand and the patients do more of this withdrawal. And then there's something that comes from the social psychology literature. I wouldn't say it's all that well established, but we thought since it's part of this canon of effects for language, we should look at it, which is called linguistic intergroup bias. And it has to do with the abstraction with which we talk about outgroup members. And basically what we thought is that based on that literature, physicians with high implicit bias would use more abstract language when they talk to a Hispanic patient. So what we wanted to do was see if we could document any evidence for this, what we're calling implicit linguistic bias, as a novel pathway by which implicit bias gets communicated. So here's how we did it. We went and recruited first through third year residents from the family and community medicine and internal medicine programs. Those are two separate residency programs in our system. We were able to recruit 53 total residents to participate in the study, many more on the family and community medicine side than the internal medicine side. And then for the patients, we needed to have patients that had enrolled to be in, to have a meeting with one of the residents who was enrolled in our project. And so we were able to get access to the patient record system and identify patients that were scheduled for an appointment with one of our residents. But they also had to self-identify as Hispanic, and this is information that's typically collected in an intake meeting before an appointment's made, or if they requested to hold the interaction with the resident in Spanish. And we thought that if the resident would know that before they came in the room, that this patient wants to speak Spanish, and so they would either get an interpreter or they would, you know, obviously be using their own Spanish-speaking skills. Importantly for us, we thought that that would activate the categorization of Hispanic, just the fact that it was going to be held in Spanish. We ended up being able to recruit 291 total patients for the study, which turned out to be 5.5 patients per physician. And so we're still trying to figure out who that half patient is, but okay. Now, let me explain just briefly how we measure implicit bias for those of you that may be unfamiliar with the particular methodologies that are used. We use what's called the implicit associations test. It's the most common measure of implicit bias in the literature. If we were measuring implicit prejudice towards Hispanics, which this one is designed to do, what happens on this task, it's a reaction time task. People are going really quickly on a computer. How many people have done an IAT before? Oh, okay, so most of you know what this is. Yeah, so what's important is early on, there's just one word up here. It's either Hispanic or white, and people are asked when they're shown a picture to decide whether it goes in this category or this category, or they're shown this picture, this category, this category. In the critical trials, they're having to do a multiple categorization where they're asked, this picture, does it belong with Hispanic and unpleasant, or white or pleasant? And this is what we call the compatible trial. It's congruent with being prejudiced, because the assumption is what's stored in memory is a strong association between Hispanic and unpleasant and white and pleasant. And that should be easy to do. People should be easy, you know, it should be an easy categorization. Where it gets interesting is when you ask people to do the incompatible trial and you just simply, you know, switch the adjectives. And now you would ask subjects with this face, does this belong with Hispanic pleasant or white and unpleasant? And the idea is that they don't have stored in memory an association between Hispanic and pleasant or white and unpleasant. And so it's hard to do that categorization. And so that's how we measure implicit bias, is the difference, look, before I talk about that, we can also do the same thing for measuring stereotyping. And in this case, we measure stereotypes that Hispanics are perceived to be non-compliant or non-adherent with medical advice. And so it's the same idea. This is compatible, Hispanic and reluctant, white and compliant, and then you can see the incompatible. To come up with a measure of bias, we just take the reaction time differences between the compatible and the incompatible trials. And people should be much slower at the incompatible than the compatible. We created something called the D-score, which is essentially the difference between those reaction times, controlling for all the variability. And then some people are just super fast. We don't think they're serious, or they're super slow, which they're being too deliberate. It's not automatic. So we delete them from the data before we look at what's going on. So that's how we measure implicit bias. In the study that we're talking about, all the residents, prior to anything happening in the clinic, did the stereotype and the prejudice IAT. We also got an explicit measure of prejudice towards Hispanics, because we want to see, is implicit bias having an effect separate from good old-fashioned racism, right? We're also interested in a lot of variables that might moderate or determine the degree of implicit bias. And so there's quite a few here. There's the degree to which they are internally versus externally motivated not to be biased. Internally is it's my value system, and I care about being a fair person. Externally is I don't want anybody to think I'm biased, right? So regardless of how I feel about it, I just don't want anybody else to think about it. Lay theories of racism, is it something you can change in people? And some people think yes, and some people say nope, that's not something you can change in people. How comfortable are they receiving feedback about their own level of bias? The degree to which they want to be colorblind and not see and appreciate differences between race and ethnicity, right? There are strategies for racial interaction. This varies from, it's something I always try to address and try to be comfortable with, to I try to avoid it. I kind of stay away from it. And then finally, we wanted to know the race and ethnicity, gender, everything we could. We also asked questions, interestingly, you'll see, about whether or not they'd had training in what a lot of people refer to as cultural competency. We call cultural humility at the U of A, which is understanding the relationship between culture and health. And we didn't in this study, but we've done in some others, ask, because it's becoming more and more common, have you had training in implicit bias, and whether that would make a difference in their IAT scores. Then what happened is, after we collected this information, and in some cases for the doctors, we collected it months before they went in the clinic, before we had a chance to follow them into the clinic. When we went into the clinic, we recruited the Hispanic patients who had been brought into the examination room, sat, their vital signs, and then our research assistants would come in and say, hey, we're doing a study, would you like to participate? And we consented them right there. And if they said yes, we left an audio recorder about the size of my phone on the table in the examination room and left. And so that's our measure of the interaction. We don't have video, unfortunately. We just have audio in this particular study. Better put that back in my pocket or I'll forget it. And then as soon as the physician comes out, the resident comes out and says, I'm done with the meeting, our research assistant's kind of waiting outside the room. We hand them a short 5-item question asking what they thought of the interaction with the patient. And then we go in and we ask the patient to complete a longer survey to get their measure of satisfaction and perceptions of the resident. And then we double check again for them self-identifying Hispanic and get some other demographic information about them. Okay, data, finally. So this is our measure of implicit prejudice and our measure of implicit stereotyping. We find in both cases significant bias towards Hispanic patients. They're showing significant prejudice here. 0 on this scale on the IAT means there's no bias, okay? So you can see that they're in the positive direction. It's scored in the direction of a positive number, indicates stronger associations, Hispanic, unpleasant, white, pleasant. And then for the stereotype, they're showing, again, a significant effect where they're associating more strongly Hispanic with non-compliant, white with compliant. Interestingly, in this data set, this doesn't always happen, but we found that both these measures were significantly correlated, moderately correlated. So much so that we decided if we tried to analyze the effects of stereotyping and prejudice separately, we'd be analyzing the same variance twice, so we combine them. So I'm going to just from here on out for this talk focus on implicit bias as sort of a combined effect of stereotyping and prejudice. We found that several of those individual difference variables correlate for the residents, correlate with their level of implicit bias in ways that sort of make sense. We did find there was a big difference for the program, higher implicit bias among the internal medicine residents than the family and community medicine residents. Although the internal medicine sample is pretty small, it's only 15 residents. I don't want to get too excited about that, but that was there. We found that the longer they'd been in the U.S. and had they been born in the U.S., they had lower implicit bias. So, in other words, students coming in to study from other countries having higher implicit bias towards Hispanics. We also found that if they had cultural competency training, they had lower implicit bias. Maybe good news for those of us that care about training, right? Of course, it's correlational, so I don't want to make a big deal out of it because we don't know what kind of training they had, whether they're misremembering what they've had. It could be just people that are highly, highly motivated not to be biased, thinking they've had that training. It's a correlation, but it's interesting. And we found it in that study with the gynecology care providers as well. So I've seen it twice now. Notice this. Implicit prejudice or bias does not correlate highly with explicit prejudice towards Hispanics, right? So they're correlated significantly, but that 0.18, that's not much shared variance, right? So, you know, more evidence that explicit and implicit prejudice are not the same thing necessarily. We also found that the more externally motivated to avoid prejudice, the higher their implicit bias. So, and this is a common finding. If I really am, you know, saying I don't want anybody to think I'm biased, that actually tends to predict higher bias. You know, if it's out here, if it's in here, if it's coming internally, that's when you get a little lower. We find in all our studies with providers, they're so high in their internal motivation to be low in bias, there's no variability. And so we can't actually often look at whether it moderates anything because there's nobody at the other end of the scale. But you find a nice normal distribution off on the external scale, and it does correlate with higher implicit bias. The less they tend to take people's perspective, the higher their implicit bias. That kind of makes sense. And interestingly, the more they subscribe to being colorblind, the higher their implicit bias. So you can see there's a lot of beliefs that some of the residents hold that probably don't correspond with maybe the best patient care. Okay, the number one question. This is a big one. Does resident implicit bias predict Hispanic patient satisfaction? We find that it does, but it's nowhere near straightforward because we find the relationship is curvilinear. And so what we find is that in the middle of the scale, there's no relationship between implicit bias and patient satisfaction. But as you get out toward the ends of the scale, so you get out toward the people with high implicit bias, lower patient satisfaction. But interestingly, and look at this number is negative, right? This is indicating stronger association with Hispanic compliant and white non-compliant, or Hispanic and pleasant and white non-pleasant, right? There's also lower patient satisfaction. So it suggests that there's a couple interesting things about this. One, to the degree there's a debate over whether implicit bias predicts behavior, I think one thing we need to start thinking about is the possibility that if we keep looking at this as a linear relationship, we may be missing what the actual relationship is. And it is consistent with the idea that people that are high in bias, regardless of the bias, kind of act in ways with people that aren't really positive, that they pick up on and they feel negative about. So we'll come back to that, but that's what we found. It's a curvilinear relationship in this data set. When we go looking at our hypothesized mediators, all those language variables, we find nothing. Nothing that we hypothesized with respect to language style matching, demand withdrawal interactions, the use of I, the pronoun I, the you, we talk. None of these correlated with patient satisfaction either in the quadratic or a linear model. So not a lot of evidence for that. However, we thought, well, you know, we've got this incredibly rich data set. We ought to go look and see what else is there. And we found that there were some variables that are pretty interesting on the language side that do correlate with patient satisfaction, or with implicit bias. And that is, doctors with high implicit bias don't talk about the future with their patients. They also don't sort of use words related to time. And we thought, well, does that mean they're not planning for another meeting down the road with the patient? And we drilled down into that a little bit more by doing what's called a context analysis. And what we found is that it primarily looks like what they don't do is when they come into the room with the patient, set the agenda for the meeting for the next hour. So that's what they're not doing, is sort of engaging at the level of, okay, here's what we're going to do, here's why we're here, with, you know, this sort of setting the agenda for the meeting kind of behavior that they're taught to do, right? That is what doctors are supposed to do. The other thing we found that was interesting is doctors who asked more questions got higher satisfaction rate, or had higher implicit bias. So implicit bias corresponds with with more question asking. But then we were curious, well, what's the patient doing at the same time? Are they asking questions? So we created a difference between the number of questions that the patient asks and the number of questions the doctor asks. And sure enough, the higher the implicit bias, the more the doctor's dominating the conversation through question asking. So we think it's potentially another form of verbal dominance that's going on. We also found some things we just don't know what to make of. Doctors with high implicit bias talk about work more, work-related words. I don't know what that is. They talk about relativity, spatial kinds of words, and they use more, they talk less about relativity, and they use fewer prepositions. So maybe shorter sentences. That may correspond with something I'll show you in a minute. So some interesting things that correlate with implicit bias. And then we were expecting to be looking at mediation, but then we realized, there's another way that implicit bias gets communicated, and that is when certain words are used by doctors with high implicit bias, that leads to lower patient satisfaction. In other words, language is moderating that relationship, and we found several variables that sort of operate this way. And so the use of I, the use of auxiliary verbs, negations, no, not, never, the use of complex words greater than 6 letters, that interrogative difference, that verbal dominance measure that we created, and we found an effect for language style matching as a moderator. Let me walk you through what these data look like to explain it. So for low and average bias physicians, there's no relationship between implicit bias and patient satisfaction when they use the word I, right? But there is for those high in bias. And so the use of I by doctors with high bias tends to relate negatively to patient satisfaction, so when they're referencing themselves in that way. No effect for that interrogative difference, that verbal dominance measure for low and average physicians, but for high bias physicians, when they ask more questions of the patients, that relates to lower patient satisfaction, so that dominance variable. And then and this is completely opposite our predictions. For low and average physicians, no relationship for language style matching, but for high bias physicians, greater language style matching relates to lower levels of patient satisfaction. So when they do the synchrony, when the synchrony is high, there's lower patient satisfaction. I'll give you some time to think about why that might be the case. We've certainly been pondering that ourselves. Or why, when they're sort of matching up their language in that way, are the patients feeling like, yuck, I don't want to do this. We also found some interesting things for physicians with low implicit bias. So for those with low implicit bias, the more they use auxiliary verbs, the higher the patient satisfaction. Physicians with low implicit bias, if they use negations, so they're using not and never and words like that. And then this one's interesting, when they use complex words, physicians with high implicit bias, physicians with low implicit bias, when they use complex words, there's higher patient satisfaction. So basically, what we found was a little more complicated than what most of us were looking for, and what most other people that have been doing this research have been finding. First, we find this quadratic relationship. And that it's really the people at the ends of the scale that are really sort of interacting with ways in patients that the patients report lower satisfaction. We also find that physicians with high implicit bias, they clearly endorse several counterproductive explicit beliefs and ideologies about racial bias and about this relationship to patient care. The good news is I think those are all addressable through training. We can get into those issues and maybe make some changes there because they are explicit. And then we did find some interesting verbal markers of the relationship between physicians with implicit bias and patient satisfaction, particularly the use of I, asking, dominating through question asking, and then this language style matching. I think what we're thinking this all means is that, what happens is when a physician with high implicit bias is meeting with a patient and they're saying I a lot and they're asking a lot of questions, many more questions than the patient is, there are other things that they're doing as they're doing these things that are sort of causing the patient to feel uncomfortable with the interaction. And one of the things that we are now doing is going through, and to the degree we can go down to the other side of that equation I showed you on the nonverbal side, looking for tone and some of these other things. And it could be, it's really both sides of that equation are important for understanding how implicit bias works, right? It's the nonverbal things people do. There may be word choices that are also part of that equation. And so we're trying to pull that apart a little bit more to understand sort of what those interactions mean. Okay, so that's the research that we've done there. Now, in the time we have remaining, I wanted to talk a little bit about sort of what we've done with respect to trying to address implicit bias in healthcare. And my colleague Gordon Moskowitz and I wrote a paper back in 2011 where we argued that, if we really want to try to address implicit bias, what we need to do is take, everything we know about the psychology of intergroup bias and bring it over and make it part of the training for health providers. But I think in doing that, it's really, really important to pay attention to the differences between sort of presenting it in a psychology course as a basic research question, right? And trying to make this useful for people that are trying to, provide patient care. We really have to tailor the materials, and there's several things that we've talked about. One of the things I know, and probably many of you know, when you try to address bias with people, there's a real defensive reaction that you get. And that's, in a learning environment, it pretty much ends the learning the minute that reaction occurs. You really have to pay attention to that, and you really have to address it right up front. So we do a lot to try to, avoid causing the physicians and nurses and whoever we're training to feel defensive and get resistant right from the start. Very, very important. The other thing that we find is that, healthcare providers, they just don't really care about basic research in psychology. I mean, it's not what they're all about. They're really interested in trying to become better providers. And so, what we realized early on is that if we're going to present any research on implicit bias, it has to be clinically relevant. It has to have been done in a healthcare setting. Otherwise, it just doesn't make a lot of sense. The other thing is there's a lot of ways that we think we know from the basic research in psychology to reduce bias generally, implicit bias in particular. And, rather than focus on one or two, why not just sort of create, many opportunities, many different ways for people to do this. But importantly, present them as clinical skills. And so really make sure that when we come to present this material to medical students, for example, that it's presented as this is a skill you can learn that will improve patient care. And then one of the ways that I know physicians and other providers learn is through doing, not by just sitting in a classroom and reading, but by actually doing. And so it's important to create what we think of as active learning exercises where they're actually practicing the clinical skills, practicing the bias reduction as clinical skills, and then getting feedback on how they're doing with it. So that's what we set out to create. Now, one of the things with respect to changing implicit bias that's important to consider is what's the change you're actually trying to make psychologically for people, right? And one way to go about this is to change the associations. So, when I showed you the IET with the categorizations and those associations, you could just change it so that people automatically try to think Hispanic good, white. You don't want to necessarily have them think white bad, but try to change that automatic link. Turns out that's possible, but very, very difficult to do. It takes a lot of training to make that happen. But there's an important reason in healthcare as to why, in fact, I don't think that's going to be an appropriate change to make. And it has to do more with the need to help people understand how to control their biases. The reason that's important, this is a great example of what this gets at. This is a short essay that was written by physician Sally Sattel. She says, "In practicing medicine, I am not colorblind. I always take note of my patient's race. So do many of my colleagues. We do it because certain diseases and treatment responses cluster by ethnicity. Recognizing these patterns can help us diagnose disease more efficiently and prescribe medications more effectively. When it comes to practicing medicine, stereotyping often works." And this was something that we got very early on when we started trying to do our training with medical students and providers, them saying, well, what do you mean I can't think about race or ethnicity in trying to diagnose a patient? That's what I'm taught to do. And of course, what they're talking about is there's two ways in which physicians learn as part of their medical training to use race, ethnicity, gender, sexual orientation, any categorization you care to name is in part of working up what's going on with the patient. One is the use of epidemiology, right, which is clustering of disease by groups. I mean, that's useful information if you have a 55-year-old Hispanic male showing certain symptoms to kind of go to the epidemiology, what happens in this group, and that's medically appropriate to do, right? The other is through, if to the degree somebody has, learned cultural humility, learned about the relationship between culture and health, and they're trying to use that to help a patient out, well, that's also going to be what I would call the process of stereotyping, categorization, activating beliefs about the group, and then acting on it, right? So we felt that it's probably not going to be effective and appropriate to tell doctors not to rely on what we think of as stereotypes. Instead, what we do is we focus on what the literature suggests is reactive control, controlling how you use the activation of stereotypes, even if automatic. Even if this stuff, this information is coming to mind very quickly for you, you can still kind of slow down and learn to control it. So basically all of our training focuses on showing providers how to switch from using stereotypes to individuating the patient. To go through the process of, okay, I've sort of used the group-based information, now let me treat you as an individual and provide the best care I can. Another way I've seen it said is using stereotypes as a starting point, not as an end point when diagnosing treatment and illness. The other thing to consider is, especially in a medical school, when you have an incoming class of students, those students in the US can be very, very diverse, right? Who are you going to be changing? Who should you be trying to change in that context? Certainly majority group students in the US, that's white students predominantly, and all the implicit bias research, most of the implicit bias research really focuses on changing that group's implicit biases. But it raises a really important question because you have, in some cases, very large samples of minority group students in the audience, right? And how are they going to respond to this? And when we started to think about that, we realized that, well, there's really sort of two groups of minority students in a US medical school incoming class. There are the students that have been, for their entire lives in the US, the target of the non-compliance stereotype. And that's predominantly Hispanic, African American, American Indian students, medical students. They grew up in the US where, they were identified early on as kids with physicians, as members of those groups, probably treated as non-compliant, and may have developed, if they don't have the associations, they may have developed control mechanisms so that they may not even show any bias on the non-compliance IAT in the first place. So we didn't think we'd find a lot of implicit bias among these minority students. We also didn't think they would have a negative reaction to our workshop. We just didn't think they'd have any reaction at all. Then you have another actually the larger group in the US, and we call them the non-targets. And they're the Asian American students, the Pacific Island students, and then a large number of international students who come from East and Southeast Asia, some from the Middle East, some from Europe. What's interesting about these groups is they're very different in terms of sort of how they've experienced the non-compliance stereotype. In one case, we can argue that Asian Americans, well documented by Susan Fisk's stereotype content model, they're perceived as competent and cold, so not as non-compliant, potentially as compliant. So they may not have the same sort of experience growing up in the US as other minorities for being treated as non-compliant, be thought of in that way. So they may have plenty of bias towards other groups in that way. And then the other interesting point that we thought is that, especially with respect to the students who come from East and Southeast Asia, they come from collectivistic cultures that value more of a hierarchical relationship between groups. And as a result, the idea of showing a preference for one group over another is not necessarily a negative thing. It's not necessarily an unusual thing. So for these reasons, we thought that we might find plenty of implicit bias among the non-target minorities, but we thought that would respond positively to our workshop, that we thought if there's bias, we should be able to address it no matter who we're talking to. Okay, so we were able to run two studies. We ran the first study in the fall of 2014, and then I kept waiting for the opportunity to go back and replicate it. We finally got the opportunity in the fall of 2017. We were able to recruit 80%, almost 80% of the incoming class in the first study, But when we went back in fall 2017, we were only able to recruit 31% of the incoming class for them. You can see how it breaks down for the majority group members and then the 2 minority group members. So we didn't get everybody in the second time for sure. Of course, as a result of that and some other differences between the 2 runs, we always use study as a factor in the analysis of the data because we want to see, is it happening the same way across studies? And then here's what we do. It's 2 workshops. A few days before the first workshop, they get access to readings. I give them an article that's written by some scholars in social psychology, specifically for providers on implicit bias. So they're going to come into the workshop. This is one of the ways we reduce defensiveness. They come to the workshop already knowing what we're going to talk about, right? Then we also asked them to complete that Hispanic non-compliance, white compliance stereotype IAT I already showed you. That's our sort of baseline measure of their level of bias before the workshops. And then 24 hours before they get the lecture notes and the readings, I write the lecture notes. It's basically just my notes on what I'm going to lecture on. And then 3 to 7 days after the second workshop, they complete the same IAT for non-compliance. So what we're looking at is, are we going to change their scores on the IAT? And you notice that there's a delay here after the second workshop. It's not immediately after. So the way this works is the first workshop is a 50-minute lecture, usually given by me, where I talk about the psychology of bias. I demonstrate implicit bias towards obese patients. I've heard some of you use raising your hand. I use the slap on the leg, which I'll demonstrate later today. And then we also, I show them a lot of studies demonstrating that implicit bias is relating to patient care. In the second workshop, they come in, and it's 90 minutes long. And again, they get some readings on implicit bias reduction, so they know what we're going to try to cover, focusing again on these are skills for controlling stereotyping. And then what happens is they're in groups of 6, and there's usually 10 groups total, and they work through these exercises that we've developed. Looks kind of like this. We talk a little bit about the importance of being aware of when bias is likely to happen, when they interact with patients, but also maybe when they're just looking at a chart and they'll still have information that they can categorize based on a chart. And so they have to be vigilant about those kinds of situations as well. And then we introduce them to a number of strategies for reducing implicit bias. So we talk about how it's communicated non-verbally in the ways that I showed you with my research. We talk about the ways in which they can learn to activate their egalitarian goals, their desire to be fair and provide equitable treatment to everybody. And so when they come into patients that are different from them, that becomes an automatic activation. We talk about how they can ask questions to look for what they share in common with their patients, because the minute we find out we share something in common with somebody, they go from being an out-group member to being an in-group member and get all the benefits of group membership, right? The big one is getting them to think about how could you get information from the patient that would demonstrate that they are counter-stereotypic. So if the stereotype about that patient's group is that they're non-compliant, maybe that's the most compliant patient on the face of the planet. How would you know that if you don't go looking for that information? And it's very interesting to ask people to do that because they're very first resistant, because to do it you have to think about what's the stereotype I'm trying to defeat. And then they say, I don't want to stereotype my patient. It's like, I know you don't want to do that, but I'm teaching you how you can do that and then get information that will, all kinds of things happen there. And then finally, we spend some time talking about perspective, actually gaining, not taking, which I think is different. And then we finish by having them think about how you have to plan to use these strategies. It might happen for you spontaneously, but it's even better if you think, when I meet with a Hispanic patient today in the clinic, I will look for common identity information. I will look for counter-stereotypic information. So there's actually a plan for what they're going to do. Okay, data. Does it work? So this is the pre-workshop IAT, and we do find an effect for group, but we also find a significant interaction. And what the interaction shows is that among the majority white, there is significantly higher implicit bias among the male students than the female students, although both of those scores are significantly different than 0. So they're both showing significant bias. It's just the males are showing significantly higher bias. Notice that the minority non-target sample is also showing significant implicit stereotyping of Hispanics as non-compliant. So these are the Asian and Southeast and East Asian students. And there's no difference for gender. And then this difference isn't significant. And those scores are not different than 0. So as we thought, the minority targets, the African American, Hispanic, and American Indian students are not showing any implicit bias right from the start. What happens after? We get just an effect for the group, no effect for gender. And what we find is that majority group members significantly reduce their implicit stereotyping of Hispanics compared to the pre. However, I want to live in a perfect world where I can get rid of bias completely, and we didn't accomplish that because their score is still significantly different than 0. So there's still significant association of Hispanic with non-compliance, but it's significantly lower than it was prior to the workshop. We get no effect for the non-target minorities. They don't show any positive reaction. And we get no bias at all among the minority target. So this is as we had hoped. This did not work as we had hoped, and that was essentially as we expected. And if you're curious about what was happening with gender for the majority group students, I was, I'll show it to you real quick, and that is we get a significant reduction for both the white males and the white females, but only the white females are now showing no bias. And so, yay, we did reduce the white females down to that 0 point, but the males are still showing significant implicit bias. So they do reduce, but not as far as I'd like them to go. Okay, so we think, or argue anyway, we have evidence that a brief active learning workshop may be effective for reducing implicit bias among medical students. It looks, at least from this data, that it was most effective for the female majority group students, and definitely less effective for the minority non-target students. And of course, we've been trying to figure out what went wrong with the intervention in that regard. Didn't make things worse, just didn't change anything. One of the things that occurred to us after the fact was that every example I show them that's doctors showing implicit bias towards patients is white doctors, minority patients, and there's never any Asian doctors. And so they may not see themselves in the material. They may also not see themselves in me. I'm a white male, and maybe there's an identity issue that's interesting to think about. I get this question a lot. It's a white male doing, trying to study implicit bias. But that could be a real issue with respect to being able to identify with the person who's sort of bringing the message, and I think there's something to that. There's also, the possibility that there's just real cultural differences in the perception of bias, and I think that that's an interesting issue that nobody's talking about very much in the implicit bias literature that we should pay a lot more attention to. One of the things that I'm excited about, though, is our data is a little inconsistent with a lot of other people that are doing this work, which is they're not finding that these effects last for very long. And what I like about our finding is it did occur 3 to 7 days after the second workshop, so it did last. That's consistent with what Trish Devine found in her well-known paper in 2012, but it's inconsistent with what Calvin Lai and others have found. And so when I think about what's the difference between sort of what we are doing and what other people are doing, I think that I'd go back to what I said before. We worked really hard to tailor the intervention to make it skill-based for providers, right? We also didn't just present them as abstract ideas for reducing bias. We actually had them do the exercises, work with the material, try to learn these as skills, right? And then, of course, we gave them multiple things that they could use. And it's common for people to come up afterwards and say, man, I really didn't like that counter-stereotyping strategy, but that common identity strategy, I'm going to try that. And then somebody else will come up and go, I didn't like that common identity strategy, but that counter-stereotyping strategy, I want to, so it's sort of like you give people a smorgasbord of things they can try, right? And people might find their way into it through different things. But we give them lots of things, and we always say, hey, if you try something that doesn't work, try one of the other ones, right? So there's a lot of things that we offer. What are we going to do in the future? Well, I would like to replicate this with a more representative sample of medical students from all the groups for sure. Our sample of target minorities is very small in this data. And then, of course, the cross-cultural issue, I think, is an important one for us to address. And then finally, big deal. We can change scores on the IET. If that doesn't translate into new behavior, it probably doesn't matter, right? And I think that's a critical question. And so what we're doing right now, our currently funded research, is we're basically taking our intervention to the residents, hitting half of the residents with our intervention, and then following them into the clinic with the Hispanic patients and recording those things. So we're kind of combining the two studies, if you will. in the study. And so we'll get to see whether or not our intervention actually translates to something more positive in the clinic. Okay. Boy, I cannot do this work without a lot of help, and I just want to make sure that I acknowledge all my great collaborators, all my students, all my colleagues in psychology, but boy, I certainly couldn't do this work if I didn't have a lot of support from our College of Medicine, our health sciences, and I just, really feel blessed to be able to do this work with their support, and of course, we get some good funding that helps as well, so thank you. Oh, absolutely, yeah.
Okay, guys, thank you, Jeff, for that great presentation. I think we've got time for a couple of questions now, and then maybe after we break, if people want to catch up with Jeff, that'd be great. So does anyone have a question for Jeff? Oh, Ricky.
Thanks, Jeff. That was really interesting. We found many sort of similar studies here amongst medical students in New Zealand. My question was around the sort of conflation of stereotypes and epidemiology, really.
Mm-hmm.
I'm not quite sure that it's the same sort of thing, like John DeVideo talks about that in terms of stereotypes being an over-generalized sort of belief and applying, I'm not quite sure I'm getting it, but applying sort of epidemiology in terms of health outcomes, I think is different than applying sort of stereotypes around things like competence and other sort of general negative stereotypes around particular ethnic groups. And the other thing I think that's slightly problematic with applying the epidemiological stereotypes is that sometimes our epidemiology is a little bit victim blaming as well.
Mm-hmm.
And so I think it can, bring into play some of those things. So I'm not quite sure about the idea that they're the same thing.
Mm-hmm. I think the psychological process by which you use epidemiology is the same thing, right? Categorization, activation of beliefs associated with that category. That psychologically is probably the same, and which is why when we're saying we want you to do something different with that process, it becomes, at least I haven't found the right narrative to be able to say, well, that use of categorization to belief activation is okay, but the other one isn't. Part of what we do in the training that may get us a little closer to that is trying to show them that you can do that in a useful way, but you can also do that in an inaccurate way. Yeah, so that's actually part of the narrative in the workshop, is what I call schema-based processing, which is the sort of the appropriate use of epidemiology, and versus stereotyping, which is what most of the, I think, medical students and faculty associate it with or think of as wrong, right? It's wrong to stereotype, but it's okay to, sort of use group-based information in diagnosis and treatment. And our point is mostly that those are psychologically equivalent. What we have to learn to do is be able, I think, to avoid the mistakes that can come from doing that, over-reliance on that, by that shift from, let me do that, but then let me do something different. And sort of what we think is important to point out is a lot of times the mistakes come from when you do it and then you don't do the other thing, right? You just, quickly, so exactly like the example I showed. Oh, it looks like a homeless hippie, gurney, and then almost died from diabetic shock. That's the, let me look at you, figure out what to do, and I don't go beyond that information, right? As opposed to looking at that, making that categorization, that decision, but then following up. That's what the nurse did, right? The nurse grabbed her and said, you need to individuate that person. Yeah, so I think that's why I pitch it that way, is that I think psychologically we're doing the same essentially the same thing. And the fact that one's evidence-based and the other one, you could argue, is not, right, doesn't really change the fact that the way you get there is the same way. And that's the problem. That's the problem we're trying to overcome, is that process issue, if that makes sense. Yeah.
Thanks very much for your talk. I just wanted to ask if you have any experience or insight into how working with medical students can be supported by work with their seniors, and the people. So it's one thing to learn things
A little bit, because I hear it all the time. You know, I've had conversations with medical students where they've told me exactly that they'll come to our workshop and then they go on rounds with their mentor, and their mentor is doing all the stuff I just talked about. It can be bad. And they're confused as to what they should follow, right? Because their mentor is the person teaching them to be a doctor. You know, I think I always come back to the fact that, well, if you care about equitable care and you care about, you know, cutting down on the number of errors you might make in sort of how you interact with patients or the decisions you make, you know, the mechanisms we're talking about here in these processes, you know, the research would suggest are useful ways to do that. But the idea that every intervention is going to work with every single person, I gave up on a long time ago. I've been teaching in college, university classrooms long enough to know that you know, not every student likes my class, and I'm never going to get over that. It's never going to happen that 100% like my class. And it's the same sort of thing with interventions. You know, there's a dosage sort of effect, right? And if you're effective, the majority of people take something away that's useful. So I always hope that that's what they leave that workshop with, is when they're in those situations and they see the mentor doing something they don't like, that they go, I don't like that and I don't want to be like that. I want to be more on the side, you know, that I learned in class, or not just my class, but some of the other classes, like the class on cultural humility, for example. And that becomes their guide, you know, as to how to navigate those situations. But it's tough because I've heard them, you know, get into arguments and, you know, and now their career is in jeopardy, right? Because faculty's unhappy because something, you know, so it's a tough situation for them to navigate. I know at the U of A for me is University of Arizona. I keep saying that, University of Auckland, probably U of A as well. They've really done a lot, because they hear about this enough, they've done a lot now to, I think, where the students all feel like they have someone else they can go to if they get into a situation that might create, right? So that they're not like, oh, I guess I just have to be a biased doctor. You know, and so I think that they're recognizing that context matters, and that everybody needs to be on the same boat. And if they're not all on the same, you know, then there's someone you can at least go talk to that's not your mentor that would help you navigate whatever could be going on. So that helps, I think. Yeah, but that's a real problem. Yeah.
Okay. Oh, yep.
Thank you for that. I'm wondering about this thing with the Asian students who
Uh-huh.
are responding to. Is there any relationship between motivations to become a doctor?
Oh, I don't know. That's a good question. What are you thinking?
I just do get a sense that some of their motivations aren't necessarily about providing
Equitable care.
society. I think they may be about family obligations and a sense of status that comes from that kind of thing. And I do know that's quite important in the rationale why many of them, or some maybe, want to become medical professionals. And so the whole emphasis on equity, maybe it has a different, it is different in their sense of whether or not it's important to me to be a really highly competent professional. I'm just wondering if there's any relationship between.
Yeah. Yeah, that's really consistent. I feel like I'm feeding back here. I think that's really consistent with some of the things that we talk about in the paper that could be along the lines of the cultural differences and the perception of bias, right? So the goal for, you know, everything about...
Might be the perception of equity.
Yeah, that's what I was going to get at. So the goal of medical care in the U.S. is pushed as equitable care for everybody, right? And that may be somewhat sort of antithetical to their cultural beliefs that they bring with them about, you know, I'm not here necessarily for that. I'm here for some of the other, you know, things that you're pointing out. Yeah.
Maybe a more inherent belief that people aren't equal.
Right, and that's that hierarchical...
We have a,
Yeah.
you know, even amongst the kind of white, non-white binary, you know, everybody wants to understand that we're all, and I mean in your country, it's enshrined in the kind of constitutional framework. But I don't know that everybody actually believes that.
Right.
And I
Yeah.
do see that here. People don't want to admit it, and, you know,
there has been a bit more of that being written about, oh, come on, we all need to get real, that actually not everyone does believe everybody has the same rights, for instance.
Yeah.
Everyone's children have the same rights.
Yeah.
And I'm wondering if there's some of those more honest conversations might be
Yeah.
fueling some of that lack of uptake.
Yeah, you're making me realize that probably with all the shootings that we've been through, maybe some of the stuff has kind of happened to us already, right? And that's why we're at each other a little bit. Is it's allowing people to be a little more honest about how they really feel. But I think back to, and don't mean to cut you off, but I just wanted to say, yeah, that the main emphasis on the medical training that I think the white students respond upon is a social justice message, right? That everybody, oh yeah, very much so. Very much so, yeah. I think the training in the U.S. is very much, sort of the idea that everybody gets the best care we can provide, and that is your job. If you're going to get a medical degree from us, that is your job.
Yeah,
but
that is your job is different than this is the society.
Right. Well, I guess for the white students, that's a message that, as you said, is kind of built into the Constitution, and it's something they've been hearing since they were little kids coming up. And so that's consistent with what their value system already is. What they want to believe it is anyway. But yeah, I think that's sort of what you're hitting on exactly what we think may be going on for the Asian students or the non-target, is that they're coming from cultures where that isn't the message, right? And so then they come in and this message they're getting, and they're like, that doesn't seem consistent with sort of how I think about these things. But I like the attention to the other goals that might also be sort of, more salient for them. That's something we hadn't thought about, but I think that's consistent with that, so that's good. So were you going to add to that? Yeah.
As an educator of med students in Māori half, and we do some active interventions. One's called the hui process, where we try and help them to model out an interaction that draws on Māori cultural values around how to whakawhanaungatanga and mihi, get to know, do that step, not just get straight into history taking. My experience is that the Asian students are very unresistant to learning that, and that they can relate quite easily to the need to do that. And whether that's a cultural issue, maybe not quite typical what you're saying, but have a personal experience. I probably have less resistance from the Asian students, but that's all anecdotal and just my observation.
Yeah, and that may also be the conscious process, right? And so, we're trying to sort of activate a control mechanism that is a conscious process. So I don't know, maybe it should be working. I would think if that were the case, it would work, and because we're handing them all these strategies they can use to control. Yeah.
Some cultures have power distance. They've got a high power distance, which is acceptable in their culture, and that's
Mm-hmm.
not just an Asian thing. It's lots of cultures like that.
Yeah.
Do we still high power distance? No, we're low. We're a high egalitarian culture. That might have something to do with it. It's a point.
Yeah, that's part of that literature on cultural differences that could influence this as well. Yeah.
All right, I might bring the questions to a close, but do hang around. I mean, Jeff's here for the afternoon and might be interested in following up some of these conversations. But thank you. Where are you? Thank you again, Jeff, for your expression of manaakitanga, sharing your research, and then your offer to hold a workshop with us this morning. It's been a great session with you now, and just want to thank you for your time and give you a little gift from the Tōmaiora Research Group to say thank you.
Oh, thank you.
Very nice of you.
Thank you.